Well, hello, this is Dr. Philip May. I'm going to be speaking to you today on the issue of disuse osteoporosis in adults with developmental disabilities. And I will be discussing the physiological adaptations to chronic vitamin D deficiency and or hypocalcemia, which may lead to disuse osteoporosis. And this is probably a common condition in adults with developmental disabilities who tend to not get a lot of weight-bearing physical activity for various reasons. Okay, before we get started, I want to review with you just briefly normal calcium balance. We're going to be emphasizing the importance of calcium here. And looking over on the left-hand side of the slide, you can see that if you have a diet with 1,000 milligrams of calcium intake per day, which is fairly typical, that some of that will be lost in the feces, as you can see, 800 milligrams, but there will be some absorption, and of course vitamin D will enhance that absorption from the GI tract into the bloodstream. And if you'll follow the arrows up to the top there, you see that there is a balance between bone and blood, that the bone supplies 200 to 500 milligrams of calcium per day, and the kidney down below, notice that next to the star, the blue star there, that 9,000 milligrams of calcium is filtered per day, and almost all of that is reabsorbed. And this is I guess the most important point of this slide to remember, is there's a lot of calcium that goes through the kidneys, but it's almost all reabsorbed. And vitamin D plays an important role in promoting, along with parathyroid hormone, the reabsorption of calcium from the urine. You could imagine if the kidney were not doing its job, you would be losing all the calcium, and you would have to take that from the bones to make up for the loss in the urine. So evaluating calciuria, how much calcium is lost in the urine, in people with developmental disabilities, is an important consideration. But this is a useful slide. I'm not going to go over all the details here for this talk, but you may want to study this a little bit and learn about calcium balance and in your evaluation of people with developmental disabilities. Okay, just here's a graphic of the renal reabsorption of calcium. You can spend some time reviewing this, but I just wanted to point out that there's a lot to it. That on the left-hand side, it shows the urine side, that calcium is absorbed from the urine through the TRPV5 channels, which are genetically determined, and the calcium molecules are attached to calbindin and transported across the cell onto the blood side on the right-hand side, where you can see there are a couple of ways that calcium can be reabsorbed, either with the NCX in exchange for sodium, or the PMCA1B channel, which pumps the calcium into the bloodstream. And these processes are influenced by estrogen, vitamin D, and parathyroid hormone. So it's important to keep in mind that the reabsorption of calcium from the urine is a complex process, but it's important for the primary care physicians to understand this. And move on to the intestine. There's a similar process with the intestinal cell, that calcium is absorbed using the TRPV6 channels from the intestine, and it attaches again to calbindin, and then is transported into the blood. And if these transport processes are defective or interfered with or not working properly, then this can lead to a drop in serum calcium, which then has other consequences. This slide was from the book by Dr. Wimalawanza, and I would recommend this book to you. You can purchase it on Amazon.com, and it's a very very helpful book to me in trying to understand some of the physiology here. Okay, what if you cannot absorb calcium from the intestine or reabsorb calcium from the urine? Okay, that's what we're going to get into. When the serum calcium levels drop, as indicated on the left-hand side, if you look at the red boxes there on the left, it says decrease of serum calcium, and the conditions that can lead to a decrease of serum calcium, whether it's a dietary deficiency or an impairment of intestinal absorption or renal reabsorption, which comes from vitamin D deficiency or drug toxicity or renal failure. What happens is that when there's a decrease of serum calcium and the calcium levels decrease, this stimulates the release of parathyroid hormone, which leads to activation of vitamin D in the kidney. The 25-hydroxyvitamin D is converted to 1,25-dihydroxyvitamin D, and once that happens, the activated vitamin D can then lead to increased intestinal absorption and increased renal reabsorption of calcium. This can then cause a rise of the serum calcium level, and this feeds back to inhibit the secretion of parathyroid hormone from the parathyroid glands, and a new steady state has become normalized here. So this is what I would call a level 1 serum calcium correction. If you have people who are involved with intense exercise, for example, marathon running or just very strenuous physical exercise, the muscles need more calcium, and this can cause a transient drop in the serum calcium, and this stimulates the release of parathyroid hormone to correct the calcium so that the athlete can maintain good neuromotor function. And this is a simple level 1 correction. It's caused by the parathyroid hormone activating vitamin D and allowing it to correct the serum calcium. It's no big deal. This probably goes on all the time during the day. There's adjustments made. But how if you have a severe vitamin D deficiency or your diet is very deficient in calcium, then and parathyroid hormone becomes activated, but there's no calcium in the gut from your diet, or it can't be absorbed, then you have to go to a level 2 serum calcium correction. And on this slide, this shows the level 2 serum calcium correction. When the level 1 doesn't correct the problem, the increased parathyroid hormone can also stimulate the formation of rank ligand on the osteoblast surface, and this rank ligand will interact with the rank receptor on macrophages and cause them to become osteoclasts. And the osteoclast then starts taking calcium out of bone, and hopefully that will correct the problem. And probably even with intense exercise, there may be a little bit of this going on, a little bit of osteoclast activation from the increased PTH, which is working on the intestinal absorption. Also, at the same time, activates some rank ligand and osteoclast activation, which also contributes to correcting the serum calcium level. Now, what happens if the level 2 correction doesn't work? In other words, the dietary calcium and vitamin D continue to be deficient, and what happens when the serum calcium levels fall and it can't be corrected with a level 1 or a level 2 process? Then at this point, the muscles start getting weak, and you start to lose the ability to engage in physical activity. And at that point, we go to level 3 serum calcium correction. And this happens when the loss of physical activity occurs. The osteocytes take over, which we've reviewed in another lecture, but I'm going to mention it here as well. Here, this happens where the sustained hypocalcemia leads to muscle weakness. So you can see on the very bottom there the pink circles. That's the pathway we're looking at now. You can see that muscle weakness occurs. This leads to immobility and osteocyte activation. And once the osteocyte becomes activated, then the osteocyte stimulates rank ligand, sclerostin, and pyrophosphate production, which leads to calcium absorption from the intestine, or the kidney continues to reabsorb the calcium, but the calcium does not go to bone. So this causes a rise of the serum calcium, and hopefully this corrects the problem, but it's at the expense of demineralization of bone. So again, just to review this, when the osteocyte becomes activated, rank ligand secretion increases, more osteoclasts are formed, and sclerostin is produced. Now, sclerostin inhibits osteogenesis. It inhibits the osteoblast. So the sclerostin itself may actually stimulate the rank ligand production. So loss of physical activity, loss of weight bearing, stress on bone leads to rank ligand elevation, but the sclerostin may actually play a role in stimulating rank ligand production, as well as the electromechanical factors. Pyrophosphate accumulates, and this pyrophosphate inhibits demineralization of bone. So you have a state here where the bones become the primary source of calcium, for the body, because there is a sustained and severe calcium deficiency in the diet, or vitamin D deficiency, and this is what happens when you develop osteomalacia and you're very weak, and there's no stress on the bones. The osteocyte takes over to supply the calcium needs. So this is the way to correct this, of course, is with calcium and vitamin D, and you can slow this process down. Okay, here's a graphic display of the process. This is what happens when the osteocyte takes over. And I have this slide in previous talks here, but I just wanted to review it with you here. Again, you can see with loss of physical activity, there's mechanical unloading, which stimulates the osteocytes to produce rank ligand and sclerostin, and this is a in other words, here's another way that rank ligand production can occur. It's not just with parathyroid hormone stimulation of osteoblasts. In fact, in this state, parathyroid hormone is actually suppressed because it's the mechanical unloading osteocyte process that's causing the calcium level to go up. And so you'll see a state where there'll be a normal calcium level and parathyroid hormone level will be on the low side, whereas with the level 1, the level 2 serum calcium correction, the parathyroid hormone level will be elevated. You'll see secondary hyperparathyroidism. So with chronic loss of physical activity, leading to almost a state of paralysis, you'll see a drop in the parathyroid hormone level with a normal calcium. So it's important to evaluate your patients, to try to analyze, what is the physiology that's going on. Now, I'm using the term lazy bones here. I'm talking, this is the bones that are subjected to loss of physical activity. What happens to bones that have had inadequate mechanical stress for a long period? Well, you have increased activity of osteocytes, and because of the lack of mechanical stress, and initially there's increased osteoclast activity and reduced osteoblast activity and a failure to retain calcium in bone. And this leads to an increased serum calcium, which feeds back and suppresses parathyroid hormone, and the reduced vitamin D activation, which results from the drop of PTH, leads to a reduced bone mineral density, and eventually reduced parathyroid hormone and a drop of active vitamin D serum levels leads to less intestinal calcium absorption, renal calcium reabsorption, and normalization of serum calcium, but now you have a lower bone mineral density. So in summary, this is how vitamin D and calcium deficiency can contribute to secondary disuse osteoporosis. Initially, vitamin D and or calcium deficiency lead to secondary hyperparathyroidism, which is a physiological adaptation to lowered serum calcium. The elevated serum parathyroid hormone directly and or indirectly via active vitamin D causes increased renal reabsorption of filtered calcium, as well as enhanced intestinal absorption of ingested dietary calcium. If the underlying vitamin D and calcium deficiencies are not corrected, secondary hyperparathyroidism will eventually, via osteoblast production of rank ligand, lead to osteoclast activation and removal of calcium from bone. If this process continues, chronic vitamin D and calcium deficiencies will lead to muscle weakness and sarcopenia, reduced physical activity, and reduced mechanical stress on bone. And once the mechanical stress on bone occurs, this leads to activation of osteocytes, which then leads to uncoupling of bone turnover in favor of bone resorption. Thus, with deficiencies of vitamin D and dietary calcium, the skeleton becomes the major provider of bodily calcium needs. With osteocyte activation and takeover of rank ligand production away from the osteoblasts, you see a rise of serum calcium and a lowering of parathyroid hormone with sclerostin-induced reduced osteoblastic activity and bone formation and increased bone resorption. So you'll see a reduction of P1NP and an increase of CTX. These are treatment issues to consider in the patient with lazy bones. You may be starting with a low bone mineral density, which is normal for that person. The low peak bone mineral density syndrome, for example. And the question that you should ask is bone turnover increased? And how do you increase the weight-bearing physical activity in this individual? Some people have severe neuromotor problems, and it's a very difficult thing to do. But if the reduced physical activity is strictly as a result of the calcium and vitamin D problems, it will be much easier. Now, if someone is not beginning exercise and you start giving them calcium and vitamin D, will their bones take up the calcium quickly? Do they have so-called hungry bones? They may need a lot of calcium and vitamin D to correct the problem. On the other hand, they may not. It depends upon what is causing the problem. Now, what about vitamin D and calcium supplements? This needs to be considered. There are also a number of pharmaceuticals. For example, those that inhibit rank ligand activity, like denosumab, Prolia, and there's a new anti-sclerostin antibody that has not been released. It's undergoing development, romosozumab, which you'll be able to consider in the future. And inhibition of sclerostin may be an important strategy at some times. On the other hand, stimulation of osteoblasts can occur with teriparatide or also with sclerostin inhibitors. Inhibition of osteoclasts with bisphosphonates or a newly developed drug, odonacotrib, which is a cathepsin K inhibitor, which will be available in the future. So treatment must be individualized and based on an accurate pathophysiological analysis of each patient's musculoskeletal conditions and metabolic status. So there are a lot of options for treatment now. So it's important to analyze each patient because they all have different problems. They may be on drugs that interfere with bone metabolism. They may have trouble with physical activity. They may be vitamin D deficient. They may be calcium deficient, or all of the above. So it's a very complex problem. Here are some references that may be helpful in understanding this extremely complicated condition. And thanks for listening. If you have any questions, you can email me at ifcd.pmay@gmail.com. Bye-bye.